Endocrine pathology, pancreatic tumors, carcinoid tumors, as well as Zollinger Ellison syndrome. All right, so for these pathologies, this is the end of the endocrine pathology section, and I have honestly the easiest things for you to understand about this. The first one's insulinoma. I don't remember getting a question on it, but it's just a tumor of the pancreatic beta cells, right? So you're producing a bunch of insulin, so the patient's going to present with hypoglycemia, right? Too much insulin means you're taking too much glucose out of the blood and you're storing it. Cool, all right? And you're going to see increased levels of C-peptide. That's how you differentiate it between exogenous, right? Now, it's associated with MEN1 syndrome, but who cares? Insulinoma is never going to be an answer for any of your questions. They never asked about it. Next is glucagonoma. Glucagonoma, you're going to be shocked, but they actually ask questions on it. But thankfully, it's the easiest thing in the world. It's a tumor of the pancreatic alpha cells. Makes sense. So you overproduce glucagon. But the patient is going to present with this classic clinical scenario. And you have to know this because they will say this every single time. And that's how you could put glucagonoma, and you don't ever have to think about it. It's the easiest thing in the world. You could get 3 questions right just by knowing this. It's going to be new diabetes. So patient's going to have random, they're going to be a little older, maybe in their 20s or 30s, 40s. They randomly they got diagnosed with diabetes. They'll say that in the vignette. You're going to be okay, that's weird. They got diagnosed with diabetes a week ago, they'll say. Or they got diagnosed with diabetes a month ago or 2 months ago. You're going to blow that off. That's something that I used to always just bypass. And I never thought about it. But they're trying to hint at you, hey, they got diagnosed with diabetes. So new diabetes with a necrotizing superficial rash on the groin. Okay? That is the classic vignette. They will say that every single time. If you see a patient with new diabetes and they have a necrotizing superficial rash on the groin, essentially in the bathing suit area, they'll say, so easy. It's glucagonoma. And that new diabetes makes sense. If you have increased overproduction of glucagon, that means you're putting too much glucose in the blood and you have new diabetes, right? Makes sense. You get diagnosed with diabetes. So that's your common clinical scenario. Don't forget it. So easy. The treatment, octreotide. It's a somatostatin analog, right? You want to that kind of decreases everything. Somatostatin, somatostasis. Or you can surgical resection. All right, moving on. Carcinoid tumors. Carcinoid tumors, this is a neuroendocrine cell tumor, okay? And it's most commonly in the intestines. They say in the lungs too, but in the intestines as well. And what this carcinoid tumor is that it secretes 5-HT, which just means serotonin. So this carcinoid tumor means that there's an overproduction of 5-HT, which is serotonin. And their patient is going to present with the weirdest symptoms, but they don't present until it metastasizes to the liver. So it can start in the intestine, but once it metastasizes to the liver, after liver metastasis, you will see symptoms. And that is very important. You will not see symptoms when it's in the intestine or in the lung. But right when it's in the intestine and it metastasizes to the liver, because it's the most common place to go from the intestine, once it reaches the liver, you will see the symptoms, okay? And it will present as carcinoid syndrome, all right? So the carcinoid tumor presents as carcinoid syndrome once it mets to the liver. And that is going to be someone that's flushing, episodic flushing, right? So they'll have flushing of the face. They'll have diarrhea, and they'll have right-sided valvular heart diseases. So weird, but this triad's so easy to pick out because it's so odd. If you see flushing diarrhea, honestly, that gives it away really quickly. You'll also see abdominal pain. And then if you see a pulmonary or tricuspid valve disease, boom, carcinoid tumor, off rip, easy. All right? Now, something that they like to ask is that a niacin deficiency, okay, could lead to a carcinoid tumor. Now, why does this make sense? Because all tryptophan is used to produce 5-HT, okay? So tryptophan is a precursor amino acid to produce serotonin, but it also is a precursor amino acid to produce niacin. So all the tryptophan, due to the carcinoid tumor, is being used up to produce serotonin in this cancer. So you're actually going to see the patient present with a decrease in B3, a decrease in niacin. All right. I think I said earlier that it's a cause of it. No, this is a sign, a symptom of that. Okay, pellagra. Lastly, you're going to see an increase in urinary 5-HIAA. That is very, very common for you to see. All right. Treatment, octreotide, surgical resection, but you can also give them tryptophan hydroxylase inhibitors. Well, why does that make sense? Well, if you block tryptophan from going down the pathway to produce serotonin, then you're good. You no longer have the symptoms of carcinoid tumor. You're not producing it. It converts tryptophan to serotonin. So if we inhibit that conversion, right, a tryptophan hydroxylase inhibitor, then we should be good. Lastly is Zollinger Ellison syndrome. Zollinger Ellison syndrome is a gastrin-secreting tumor, also known as gastrinoma of the duodenum or the pancreas. So you have an increased levels of gastrin. Increased levels of gastrin means that there's increased levels of acid production in the stomach. Okay? Now, what does that mean? Well, the patient's going to present with ulcers down in the distal duodenum or even in the jejunum. If you see ulcers in the jejunum or far down the duodenum It is the highest indicator of Zollinger Ellison. That's it. Boom. There's your answer. Okay. And it's due to increased gastrin. Because there's that much acid production, we never see ulcers deep distal in the duodenum or even in the jejunum. But if we have ulcers there, that means that there has to be an overproduction of acid. That's insane. And it's secondary to a Zollinger Ellison. And we'll talk about that later on in GI. But that's all you have to know for currently right now. Okay. It's just due to an increase in gastrin secretion. That's all for our endocrine pathology. Next, I'll be going over our pharmacology for endocrine in a short, small video.